Okay, today is June 28th, 2016. Kay Wagner, Foundation Archivist, is talking with Dr. Cameron Roberts, a retired diagnostic radiologist. Dr. Roberts finished medical school at the University of Wisconsin in 1971. His internal medicine residency was at Blodgett Memorial Hospital in Grand Rapids, Michigan.
That was only 1 year of
One year,
internal medicine
okay.
residency.
And then your diagnostic radiology residency was at Milwaukee County Hospital,
Yep,
correct?
yep,
And you joined Gunderson in 76 and retired in 2014?
that's right.
Okay, so that for a total of 38 years of practice here.
Yep,
Welcome. We're
thanks.
glad to have you here. Thanks for coming in. First of all, tell us about your family history and where you grew up.
Okay. My mother, Bernelda Ost, was raised on a farm near Montevideo, Minnesota, and my dad, Frank Roberts, was raised in Beckley, West Virginia. And they met in San Francisco during World War II and married in San Francisco. When I was born in 1945, Franklin Roosevelt was still president, and World War II still had about 7 months to go. My dad got out of the Navy after the war was over, couldn't find a niche in civilian life, so he joined the Army and was in the Army until 1962. So I grew up all over the country. I changed schools 13 times before finishing high school. And the last move that my parents divorced when I was a junior in high school, and my mom and I moved to Madison, where I finished high school at Madison West High and then stayed for the University of Wisconsin and University of Wisconsin Med School. So it was a pretty rootless growing up, but I sure got to see a lot of the country.
Did you have siblings?
No.
No siblings. What did your father, well, he was in the Army, did your mother work?
Yeah, she did. It was in various jobs, and that was a source of frustration for her because she'd find a reasonable job and then we'd move and she'd have to give it up. And so it always surprised me that they got divorced as my dad was getting out of the Army, and I thought that this would be good for them, and especially for my mother, now that the Army years were done. But they never discussed with me why they got divorced.
What additional information would you like to add about your education in your postgraduate years and medicine in your decision to become a physician?
Well, part of my part of my decision to become a doctor was I wanted a stable job where I wasn't going to be moving around anymore. I did not like that, especially the older I got. In grade school, it's pretty easy to fit in to a new school, but when you hit middle school and high school, it becomes pretty difficult to become accepted. So I wanted to have a job that would not be moving me around. And I want a job that with financial security and doing something that benefited other people. And being a doctor really appealed to me. I initially thought I wanted to be an internist, and I did my internship in Portland, Oregon, and as my internship year went on, I was less enchanted with internal medicine, and my last rotation was radiology, and really liked it a lot. It was too late to affect the upcoming year, and I had signed on for internal medicine residency. So I did 1 year of that and then switched to radiology. And the internal medicine year was certainly good background for me.
What didn't appeal to you in terms of it being your specialty?
There were too many things that the patient comes to you with a complaint and you do a battery of tests to try to exclude known entities, and too often you really don't discover what's wrong with them, and you can get them through symptomatically sometimes, but a lot of times it was just their body had to deal with it and heal it, or if it was something that sometimes it was something that you could diagnose but you really couldn't do much about it. And so both of those things were frustrating to me, that frequently you never knew what they had, and then sometimes, even though you could diagnose it, there was not much to do about it.
Or the patient maybe perhaps didn't disclose enough.
It's possible.
So besides the other reasons of stability and financial security, were there classes, or do you see yourself, math, science, that type of thing, were those fields that appealed to you when you were in high school?
Yeah, science did. Another appealing factor for going into medicine was the challenge of constantly trying to learn about the field. And even though I was always interested in science, my college major was German, and that actually occasionally helped with German-speaking patients that I ran into once in a while. Yeah, the challenge of medicine was appealing to me.
Did you have a particular role model?
When med school, Dr. Ovid Meyer at the University of Wisconsin he was an internist, and he was the kindest, nicest man that I think I met in med school. He was very good with patients, had an enormous fund of knowledge, and he really influenced me. I was in his physical diagnosis class, which is the class where you learn how to do physical exams, and he was pretty elderly at the time that I knew him, and so he had a vast storehouse of physical signs and physical exam tricks that you could do, a lot of which have been supplanted by modern radiologic methods, but he was a wonderful teacher and a wonderful person.
How did you first hear about Gunderson?
In med school, we got pamphlets from Gunderson's cardiovascular symposia that he used to put on, and so I had heard about Gunderson in med school, and they had a good reputation, and it sounded like a good place to go to work.
Did you look at other places as well?
Yeah, I did. When I was finishing my residency, I looked at a map of Wisconsin and picked out 7 or 8 towns that seemed to be about the right size that my wife and I would like, and I wrote to the radiology groups and in all of them asking them if they need anybody. Most of them never responded. Gunderson did respond, and at the time they did not need anybody. And so I did have a job offer from Manitowoc, which didn't appeal to me very much, and a job offer from Rice Lake that also didn't appeal to me. So I was going to stay on at the Medical College of Wisconsin as junior staff. But in the winter of '76, 2 of the radiologists that were here at Gunderson decided to leave. And so Mike Hartigan, who was on the personnel committee, and coincidentally the doctor you just finished interviewing before me, I got a phone call from him and asking if I had taken a job anywhere else. And you know, sort of I had, but being junior staff at Medical College in Wisconsin was, that's sort of a marking time thing, and not really not a real honest to God job. And so I told him no, and I came here and interviewed, and so I replaced the two radiologists that left. So when I came here, there were five. I was the fifth radiologist.
Were you assigned a number?
If I was, I don't know what it was.
Okay.
But there were five radiologists, and I was the fifth radiologist.
When you came to visit here, what were the features or the things that made you make a decision to come here?
Well, I'd had a good reputation that I'd known about since med school. I liked the setting of a clinic with multiple specialties. I thought it made it a far better arrangement for the patient, so they didn't have to wander around town to get their lab at one place and their X-rays at another place, and specialty care at a different place. So I thought it was really a good setup for the patient.
It sounds as if you wanted to stay in Wisconsin.
I did, yeah.
Mm-hmm. And did you meet your wife when you were in medical school, or?
We met in high school, but at the church youth group that we both attended, and we were both at the same high school too, but I never saw her there. It was such a big high school. And but nothing clicked at that time. And the summer after I graduated from college and I was going to start med school in the fall, I was working as an orderly at the university hospitals in Madison, and she was working as a nurse's aide. She was an occupational therapy student. And one day as I was coming on duty to an orthopedic ward, she was going off duty, and we ran into each other, and I knew her, but I couldn't remember her name. And so we chatted, and then she left, and I went to the head nurse, who had been the first nurse that I worked with when I started as an orderly at the university hospitals. Fortunately, I was on her good side, as was my wife-to-be. And I said to Mrs. Gibson was her name. I said, Mrs. Gibson, I know that girl, but I can't remember her name. What is it? And so she told me, and I called her up, and we started dating, and it was the right thing.
And how many children?
We have 3 sons, and they're all married. A total of 6 grandchildren, 1 boy and 5 girls.
And what do your sons do?
Our oldest son is the marketing manager for a RV sales company in Fort Collins, Colorado. And our middle son is also in Fort Collins, Colorado, and he's full-time in the Colorado Air National Guard. And our youngest son right now is in Chiang Mai, Thailand. His wife is a lawyer, and she has a job there monitoring International Monetary Fund and World Bank projects to make sure they're benefiting the local populace. And so they went there for her job. She was told she could live anywhere in Southeast Asia, and so our son decided he would find whatever he could when they got there. So he has accepted a job teaching at the British International School in Kuala Lumpur, which is the capital of Malaysia. So they'll be moving from Chiang Mai in Thailand to Kuala Lumpur in August.
Do you get to see them often?
Not often. They just moved over there in March, and we're going to see them next month. And they have said they plan to come back to the States once or maybe twice a year. And we'll probably go over there once a year, as long as they're over there. And they have said that they plan to come back to the States when their little girl, who's now 2, start school. So we hope that they stick with that plan. That's a long ways away for them to be.
That sounds like they're all doing well.
They are, yeah.
And at least you've got a couple that are somewhat close, although Colorado is a little bit of a distance too.
Yeah.
How has diagnostic radiology evolved in your career?
It's been enormous changes in diagnostic radiology. The first big one was CAT scans. When I was a second-year resident, we got a first-generation ME head scanner, which was amazing at the time, but now when you look at the pictures, they look hopelessly crude compared to what we can do now. Head scanning eventually evolved into body and spine scanning. This took a number of years before they could work out all the algorithms and the technology to scan fast enough to overcome the effects of peristalsis and breathing. And CAT scanning was a major change, revealing things that we could never hope to have seen when I was in training. And then MR scanning came along, magnetic resonance, and that was another major learning challenge. Then interventional radiology was another big change, in which I did not get involved in, but it was a big change for us. Digital radiology was another big change, which increased efficiency a lot and got the images out to the clinicians far faster than they could have seen them on the old hard copy images. And the voice recognition dictation system was a big change, so that reports were typed up virtually as fast as we could say them, and then we could sign them. And so by the time the images were being looked at by the clinician, they usually had the report on them too. And whereas in the past there would be a lag between dictating the report, getting it typed up, proofread and signed, and then pasted on the X-ray folder. And then the last big change was the medical electronic records, which sure made it easier to find out information about patients, since the X-ray request forms usually didn't have a lot of useful information for us. And if we saw something that on the film or on the CT scan or whatever, then we could readily look in the electronic record to find more details about the patient. So it helped a lot for us to be able to access the patient history. When Epic came along, I'm glad in radiology that I did not have to deal seriously with Epic, because it was quite cumbersome and non-intuitive, and so about the only time I really had to deal with Epic was when I was ordering a callback mammogram for a woman whose screening mammogram I had read, and she needed to come back for more images. Otherwise, I didn't have to use it much.
Well, that's another area with the mammogram that I can't think of what it's called now, but it actually with density, it's better for detecting cancer in the breast, because it can see more things.
The tomosynthesis, is that
something like that? Yeah. I shouldn't even be saying anything because I don't know anything about the field, but it kind of leads to the question of what are the diseases or the afflictions that the technology has helped the most.
Boy, that would be tough. It's helped a lot. Mostly CAT scans and MR scans to show abscesses, tumors, liver metastases, pancreas abnormalities, um, spleen problems, traumatic injuries. Some fractures show up much better on the CT than they did on conventional films, and sometimes conventional films wouldn't show the fracture at all, and you'd have to see it on a CT if, or occasionally on MR, although MR is not a strong imaging technique for bone trauma. But CT was absolutely revolutionary. That to show things that you could never hope to see on conventional films. In the lungs, it would show you tumors too small to see on the conventional films, and the mediastinum, which is the central part of the chest where the great vessels and the esophagus are. That was always hard to evaluate with conventional radiology, conventional x-rays, and the CT showed it quite well.
Did the new technology help to reduce fatality, because of the accuracy and the ability to see more things where you couldn't with an x-ray?
Sure, yeah. And it also cut down a lot on what was called exploratory laparotomies, which was a surgical procedure when you couldn't really tell what was going on inside a patient's abdomen, and the clinicians thought that whatever was going on was serious enough to do a open surgery to look around in there. CAT scans has almost completely replaced exploratory laparotomies because you can generally tell whether something is there or not.
And how does the PET scan differ from the other?
PET scan is a combination of radionuclides and sometimes combined with a CAT scan. And the PET scan is more used for looking at metastases that may not show up by themselves on a CAT scan or an MRI scan. So the PET scan might give you a general locality of a metastasis, and when it's wedded to a CAT scan, then the CAT scan will give you more detail about exactly where that location is if you pinpoint the abnormality on the PET scan onto the CAT scan.
Interesting. You served as section chief for the fluoroscopy section of Gunderson. And what other involvement, you talk about that and other involvements that you had at Gunderson beyond just your clinical practice?
Well, I was on the personnel committee for a few years. I ran a GI radiology conference once a month to present interesting GI cases with the gastroenterology department. And for a while, for a number of years, I ran the radiology pathology conference, which was discussing radiologic misses. When any of us became aware of a miss that one of our partners had made, they'd turn in the patient's name, and then we'd go over them once a month and try to learn from what we had missed.
How about with anything with medical education, research?
No.
Did Gunderson's programs in medical education and the research efforts enhance your tenure here?
The medical education did. The noon conferences were good. The research I was never very interested in. And as my career went on, I got more and more involved on the road doing outreach to the point where by the time I retired, I was almost never in La Crosse. I was virtually always on the road, which suited me well because I got to work more closely with the x-ray techs out in the smaller places. Here in La Crosse, the radiologist was getting more and more isolated in their reading rooms and less involved with the radiologic staff.
Yeah, that was something I was thinking of too, is the difference with that particular field, or even with pathologists, where you don't have as much patient contact as some of the other subspecialties. You were involved in outreach from '87 to 2014,
Right,
if my statistics are right,
right.
and served as hospital staff to about 10 regional hospitals.
That's right.
You found that interesting?
Yeah, it was. The you tended to get consulted more often by the doctors, the clinicians in the smaller hospitals, because here in Gunderson, for instance, a chest physician, who that's their specialty, they can do a good job on reading chest films, and they had less need to go talk with us about chest x-rays, for instance. Orthopedic surgeons certainly are good at reading their x-rays, and whereas when you're out in the surrounding communities, you're mostly dealing with general practitioners, and they had more need for a radiologist to help them with interpreting the films.
You must have made a lot of relationships and friends throughout your outreach service.
Yeah, yeah, that's true.
Well, thinking back to your tenure at Gunderson, what would your colleagues say that you're best known for?
Team player. I tried to do what the department needed me to do, and not complain, and if so, that would be it.
What would you say, or what should you really be known for?
I think my kindness and my respect for not just the patients, but also respect for our x-ray techs and the sonographers and the CT techs and the fluoro techs, and working with them as colleagues and not as servants.
Do you have a favorite story about Gunderson? Maybe a best day, worst day, patient?
I remember when I was doing fluoro one day, and fluoroscopy mostly involved upper GI series and barium enemas, and gradually the fluoro volume decreased as endoscopy got more and more developed. But early on, I remember doing 30 fluoroscopy cases in the morning, which is a really busy load. And I also remember doing 5 Pantopaque myelograms in one day. Pantopaque was a contrast agent that was oil-based, and when you were done with doing the films, you did a lumbar puncture and put in the contrast. And then when you were done, you had to suck out the Pantopaque because it could cause a chemical reaction with the lining of the dural sac. So doing 5 Pantopaque myelograms was a pretty darn busy afternoon. And I have very fond memories of Dr. Roland Locher, who was one of the radiologists here who tragically died at the age of 55 from a brain tumor. And I've missed him ever since he left. He was a great colleague, and really enjoyed working with him. He was chairman for 10 years also.
Did you have much interaction with Dr. Overholt?
Not a lot, but he would come around with his entourage back in the days when you still had to check out your x-rays from the file room because they were hard copy. And one day I was walking by the viewing room after he had checked out a CAT scan on one of his patients. And at that time, again, the CAT scan was printed out on numerous sheets of x-ray film. When we went digital, then it was a lot easier to view them. But so he had several view boxes filled with the CAT scan, and I overheard him say to his entourage, "How did we practice medicine before CAT scans?" And to come from Dr. Overholt, that is probably the ultimate compliment that this particular technology could ever get. He was a tough cookie to sell on anything new, and he was a terrific doctor, and it was fun working with him, even though it was just sporadic when he would occasionally call me in to look at films with him.
Do you have any advice or words of wisdom to offer young physicians entering diagnostic radiation or medical school today?
Always respect your patients, and always respect your paramedical personnel. You can learn from your patients. You can learn from your nurses and X-ray techs and sonographers, and don't think that MD after your name makes you something above them.
What are you doing in your retirement?
We travel as much as we can. We go out to Colorado fairly often to see our two oldest sons, and we've got a family vacation home which is up in the Colorado mountains. It's not where our sons live, but they can get up there too and use it when we're not around. I'm in a bagpipe band here in town, so I play bagpipes, and my wife and I are involved in volunteer activities at the warming center that the Catholic Charities run, and other voluntary activities too. And we're pretty active in our church, which is First Congregational Church.
Did your wife, did she continue with her career as an OT?
She did. She never had to write a resume, because people would hear that there was an OT in town and they would call her. She never had to apply for a job. She never had to write a resume. They came looking for her. And so she had worked for the school system here, and she worked for a couple of the nursing homes, and then for an outfit called Salucare, which provided OT and PT coverage for various places.
Is there anything else that you'd like to share that I have missed? Just memories that are part of your experience?
No, I think that's about it. I've really enjoyed being at Gundersen. I still think it is the best situation for patients. They can get all their care in one place and not have a big runaround, and not have, well, communications in medicine can be an issue, particularly if you're dealing with, as I mentioned before, dealing with a lab at one place and a radiology facility at another place, and a specialist at a different place. Whereas here at Gundersen, with a unified medical record and ready access of the docs to each other, the missed communications are much reduced, and I think patient care is far more efficient and patient-friendly than it is in a non-clinic situation.
How about the electronic medical record? Maybe that you said you probably weren't here when Epic came up, but we hear sometimes that it takes away from patient interaction as you're having to type in your notes while the patient is there. I mean, there's good and bad sides of that.
A lot of, well, some of the complaints I have about Epic are probably of no concern to younger docs, because I think there is a big generational thing about using computers. Younger docs that grew up with computers, Epic may be second nature to them, and whereas for me it was an issue, even though I did not have to deal with Epic very much. and I don't know how much younger docs feel imposed upon by having to type up their own notes. Again, I had voice recognition for my reports, so I didn't even have to type my own reports. But well, I never did. There were secretaries before the voice recognition, but I know now the clinicians have to type their own notes into Epic. It would seem to me that would decrease their efficiency, but maybe it's not an issue for them. I don't know.
I don't know. Probably six of one, half a dozen of another, as far as what who likes it or who doesn't.
Mm-hmm.
But I don't know. It probably does eat up more time than they're. But that's what they're used to as well. So they don't have anything else to compare it to.
Mm-hmm.
Jay, did you have anything that you were thinking of that? Well, it was great that you could come over here today and visit with us. And what will happen is, I'll be sending you an unedited version of the interview so that you have that. And I think I told you before we started kind of what the uses will be for the interviews. Mm-hmm. Did I?
Yeah.
Okay.
I think I kind of know, but I'm glad you're doing this. I think it's good to record the memories of people who have been here, and it's interesting to look back and hear how things used to be.
Well, it's my pleasure to do the interviews. I think that it's well worth it.
Okay.
Yeah.
Thank
Thanks
you
again.